Together, their proposed research works span from methods to applications, including AI agents in health, biomedical foundation models, as well as causal machine learning on real-world data sets. We'll hear from the experts next. So I'd like to invite Professor Farah Shamout on stage, please. Thank you.
Okay, thank you very much to the ADIA Lab team. I'm very honored to accept this grant. And I'm very happy to give you a 10-minute presentation about what we plan to do, but also some thinking about why we got to propose this solution after years of research working on clinical decision support systems. So I'm going to begin with this very good AI-generated image of a hospitalized patient. And I think with healthcare, we all get to interact with the healthcare system. We know how stressful it is to get sick and to even get to the emergency room and eventually get hospitalized. And one of the things that I've been really interested in since my PhD work is to build systems that can better alert for clinical deterioration. And in simple terms, clinical deterioration refers to the worsening of a patient's condition such that they eventually have cardiac arrest, they need to get admitted to the ICU, or unfortunately, they may pass away. And undetected clinical deterioration usually leads to very prolonged hospital stays, unexpected and expensive treatment plans, and generally bad outcomes for the patients. And for hospitals, it's extremely important to improve patient outcomes as part of their clinical quality review cycles. And this is a quotation from a tweet that, from a presentation, but later a tweet that was published a couple of years ago during COVID, actually. And it says, patients don't suddenly deteriorate, healthcare professionals suddenly notice. And this in no way blames healthcare professionals, but rather highlights the challenges in healthcare settings, because there could be understaffing, so there are shortages of staff, there could be lack of resources, and many other reasons that could sort of distract healthcare professionals from actually detecting or noticing that some patient is about to deteriorate. So really this motivates my work for using AI to build risk prediction models in hospital in order to alert clinicians and eventually improve patient outcomes. And since the 1990s, early warning scores were presented in order to detect if someone is about to deteriorate. And as you can see in this chart, it's very simple. If their, for example, breathing rate drops below a certain measure, then the score could be 3. If their heart rate is high, then you assign a higher alerting score. So they're very simple, originally heuristic, actually, methods in order to detect if someone is at risk. And these early warning scores in this form are actually currently being used in hospitals around the world. So NEWS was established in the UK, and it's also being used in some hospitals in the UAE. And for some of the work that we've done as well, we actually evaluated the accuracy of these scores on the UAE population. And we also noticed that these scores have very low accuracy and precision. And this is expected because these scores are based on heuristics, because they were also developed in the UK, so they were kind of developed for a completely different population, but they're still being used. And why are they being used? My hypothesis is they're very intuitive. So they're very easy to understand. The clinicians can actually calculate the scores on the fly, and they just work well within clinical practice. But beyond these simple early warning scores, a lot of our work for the past couple of years has been focusing on developing AI-based techniques for detecting and predicting deterioration. And we've worked with and developed many deep learning models, including time series-based models using LSTMs, recurrent neural networks. And most recently, especially after the pandemic, we started looking at multimodal early warning models. So we, especially in the context of COVID-19 patients, we started looking at how can we, for example, combine chest X-ray imaging with clinical data or EHR data. And this started with simple approaches with late fusion models. We then looked at joint fusion approaches in order to improve the quality of the representations that are learned by these deep neural networks and in order to improve accuracy metrics, essentially. And we have a lot of follow-up work that was published in the past year. So we also looked at incorporating other modalities beyond imaging, so radiology reports and clinical notes. And my team is here, so they're very happy to see screenshots of their work on the slide. And we also looked at other sort of technical challenges related to, for example, enhancing learning rate schedulers for multimodal neural networks, federated learning frameworks for heterogeneous data modalities across multiple institutions, and so many other sort of technical questions related to multimodal learning and clinical deterioration prediction. But through our work, we also engage very closely with clinicians. And when we discuss with them and just present a simple multimodal network, for them, this is just another tool that will eventually be deployed in clinical practice. But also for them, these models are not really intuitive. So they're not just interested in a single prediction because they already have an overflow of information on a day-to-day basis. The second thing that we noticed, especially with ChatGPT and all of these tools, is that clinicians actually like using ChatGPT and other LLMs. And this is because they rely a lot on narrating sort of the context or answering in text, which is obviously much more intuitive than just getting a number that indicates if someone will deteriorate. We also had one PhD student, Farah, who even shadowed a clinician in the ICU. And one of his key observations was that the patient monitoring process in the ICU is extremely collaborative. So the nurses usually are the ones who are patient-facing. They record the data, they process it, they write progress notes, and then the clinician actually reflects on what is the best way to treat the patient. So it's a very collaborative process. It's not a single model that necessarily guides the patient clinical workflow. And another, I think, important insight from clinicians, they told us they already know if someone is going to deteriorate. When they see a patient, they already know that they look sick, they're already in a bad state, but what they're interested in knowing is how will that happen, when will it happen, and why will it happen. And I think with these simple fusion models that we've been building that provide a simple score, although it's promising from a technical perspective that we're boosting performance in order to detect these high-risk patients, again, they're not very intuitive. So that's why we're proposing Agenti CDS, or a multimodal agentic system for clinical decision support, where we're hoping to build upon the work that we've done so far in order to use these multimodal approaches and methods as techniques or tools to support clinical decision-making as part of an overall framework that also integrates large language models for reasoning capabilities, but also to integrate other sources of information that might not be easily captured by those hyper-specialized models. Because as you know, to build a simple models for, let's say, for hospital mortality prediction, you need to train the model from scratch, clean the data, and so on. So instead of having to do that repetitively and update these models in order to use just a single model, instead we can just plug and play these models as tools that could support the full multi-agent workflow. So this is a high-level image of what the solution looks like, but we're envisioning that we would have specialist care agents that would, for example, nursing agents that would assess the patient's EHR data, like their vital signs, their labs, and then we would have radiology agents, because there are many medical images that are collected during a patient's hospital stay. And as you can see, each of these agents would be responsible for either a point prediction, so we can also combine these traditional deep neural networks, but also some text-based tasks like report generation, providing an explanation, things that are more acceptable by the end user. And I think one important element, which I guess has been mentioned in some of the talks today, is patient safety. And for that, we have this sort of bottom row that shows another perspective, or another important pillar, actually, of what we're proposing is having some kind of safety mechanisms that could also alert for errors and potentially correct them. And we're hoping to evaluate this work using a large publicly available data set, but also partner up with NYU Langone Health, our School of Medicine, and also Cleveland Clinic Abu Dhabi, who have been working with us for a while. This is our team. So this project is co-led by my co-PI, Professor Muhammad Shafiq, also at NYU Abu Dhabi, and some collaborators at NYU and NYU Langone Health, And we're hoping to hire a postdoc through this grant. So if you're interested and you've done some work in multi-agent systems, please feel free to reach out. So I'm going to sort of close with this study that I came across recently. So this was published in, over the summer in the Lancet Child and Adolescent Health. And you might wonder, how is this relevant? But in this study, there was one interesting finding where they actually had a prospective cohort study to check whether the concerns of caregivers or the parents of children are associated with adverse outcomes or clinical deterioration events. And what was interesting is after accounting for some confounding factors, they actually noticed that the concern of parents is associated with eventual bad outcomes of the children, which means these parents are acting as advocates for the children, and care providers should take into account their concerns. And I think this is one way we can think about those AI models, especially in the context of multi-agent systems, that as we improve their performance, we can also think of them as patient advocates. Because they're there, they can overlook sort of the full patient history, their symptoms, their modalities, and then provide additional information for caregivers or hospital staff in order to sort of better plan treatment and in order to eventually have better outcomes. And so the expected impact of this work is that we want to move beyond point predictions, and this could be applied for other use cases. So it could be applied for breast cancer diagnostics. We also have some work related to IVF. So we're really hoping to gain some insights from this initial use case and then apply multi-agent systems to other problems. And the other advantage is that the framework could adapt to new data sources. So as I mentioned, considering the fact that you can plug and play models, it means you can actually learn from other modalities over time without having to retrain like a single foundation model. And eventually, we want to streamline clinical workflows. I visit the hospital every once in a while, especially for my daughter when she gets sick. And we waste sometimes 2 to 3 hours just because we're waiting for a nurse to come and measure her vital signs and then prescribe some Panadol. So I think with these multi-agent systems, they can really streamline workflows, and they can even improve triage by just ordering tests and ordering measurements under the supervision of health practitioners or doctors. But our goal really is to work towards collaborative frameworks that leverage all the work that has been built in AI for healthcare in the context of clinical decision support and patient deterioration in a patient-centered or a human-centered fashion. So I'll stop here and thank ADIA Lab again for the award.